Hopefully, we'll have more sessions together. We'll have more learnings together. And it's always a pleasure to talk to nurses because I believe in palliative care, nurses plays the most important role. So thank you once again. As mentioned, kindly rename your ID, your name in the Zoom because we would like to know who has logged in and from where, and the chat. Please tell where you are from, so we'll get an idea about where you are coming from. What is your name? Because we are anyway going to be together for many more sessions. So today I'll be talking a little bit about. Many of you might have heard about palliative care, or many of you might have worked in palliative care, or at least seen people getting palliative care. But some people may not know what exactly is palliative care. So today we'll talk a little bit about the concepts of palliative care, what it means, especially in an Indian context, more specifically how it happens in the place where we work, and then we have some discussions around it, and then we'll wind up today's session. So I'll start with my presentation. If you have any queries, please either type it in the chat, raise your hand, unmute, and just ask whenever, even during the presentation. And I really expect interaction because this is not like your classroom session where a teacher is teaching and you're all listening. This is all adult learning process where we both will exchange our ideas and our thought process, and then based on that we'll discuss further. So I expect a lot of interaction either by chat or by giving your inputs through by unmuting the mic. So this is where I want to start with, where we look after patients who are telling us, treat my suffering, not just my disease. What do you think about this? Aren't we treating suffering? What is the difference actually? Is there a difference? Treating a suffering, treating an illness, treating a disease?
Yes, ma'am. There is a difference.
Yeah. So can you just, I know that there is no right or wrong answer, but what do you think will be the major difference between suffering and disease? Aren't we treating suffering for the patients that we see?
In most of the cases, we treat the disease, not the suffering.
Yeah. Anyone else? Thank you, Sister Kusum. Anyone else would like to comment on that? So as a nurse, are you treating suffering or are you treating disease in your practice? Many of you might be already in practicing in palliative care or any other specialty where you are treating suffering, or some people may be treating the disease. So what do you think about your current practice? Are you involved in treating suffering or disease?
I think we do both in Atulya.
Yes, yes. Thank you, Sister Saraswati. Yeah, sometimes we do both. I
Yes.
totally agree with that. But you understand there can be a difference between both, right?
Yes,
Difference
of
between the
course.
suffering and the disease. Yeah. Thank you so much. So illness or suffering is basically a patient's experience of ill health. So it constitutes so many things. It's not just the organic part of it, where you have a tumor in a particular organ, or you have a bleed in a particular area of your body. You have some electrolyte abnormalities. That's not the case. Illness is or suffering is an experience. Illness is an experience where disease is usually pertains to a disorder of organs or tissues. So what do we do generally, as Sister Kusum was telling, by and large, we focus mostly on the disease because we think that patient is coughing because of this particular illness. So our intention is to understand what is the disease, diagnose and treat so that patient goes back to normal life, right? That's the usual practice. More or less, that's what happens in a medical system. So that is okay when you have an acutely ill patient in the hospital. Suppose you had upper respiratory tract infection or a very bad GI infection, that you have severe tummy ache, fever. You go to the hospital, we might have to take leave from your hospital or from your work for a week or two. Then you're back to normal, right? Near normal at least. You will have a little bit of tiredness after 2 weeks, but still you are able to go back to work. You are able to get salary after 2 weeks. You are able to function as a family member, and you are kind of back to normal within a few days or weeks. You can start your routine activities more or less to normal. But what happens when someone is chronically or incurably ill? What happens then? It's not just a matter of 2 weeks where he's treating or he's getting treated in a hospital, he's getting antibiotics and going back. But the illness and the suffering is going to be with the patient for a longer period of time. This patient will need regular attention for the rest of his life, right? It may not be okay, it may not be cured with a week of antibiotics or some acute hospital admission, but they may have to get care throughout their life. So these are some of the examples that I'm telling. What happens to a man who fell from a coconut tree and became paraplegic? What happens then, generally? Can someone tell me? You as nurses might be seeing this very, very often. Leave apart the coconut tree. Maybe we are in Kerala, we have a lot of coconut trees. What happens to a man who had an accident and became paraplegic? A road traffic accident and became paraplegic. What happens to their life then? Medically speaking, the disease part of it. What do you think, Sister Abhirami? What happens in a typical scenario where someone had an accident, now became paraplegic?
So the patient is a prolonged bedridden.
Yeah.
So he developed a bed sores.
Yeah.
So they need
Yeah, they need a longer period of care, right? Thank you, Sister Abhirami. Anyone else?
They are becoming dependent for everything.
Yeah. And what happens? Are they going to back to their normal life within 2 weeks or 3 weeks?
No, which is not possible
They have to live with this issue for the rest of
for a
their
longer
life.
duration.
Longer duration, which needs a lot of support system, hospitalizations, nursing care, medical care, a lot of multidisciplinary team approach. The same thing can happen with a person with advanced cancer, a lot of metastasis where he may not be back to normal after a particular treatment, but he has to live with the suffering that we were mentioning for a longer period of time. The same thing with the patient with stroke. They get the stroke, they go to the hospital, many of the functions may restore. Many of the patients may become normal after a prolonged period of physiotherapy or other treatment. But some of them will be bedbound or confined to bed, or sometimes they may be able to do all their activities, but there may not be there can be speech issues. Or they might be able to talk and eat, but they may not be able to walk properly. So there can be some disability which is going to be there for a longer period of time, which needs care. And many of these situations, now we are listening all these three scenarios where generally our patients used to tell us, this is what doctors tell them. We have done the surgery, now you had an accident, we did the fixation, your spinal cord injury was the vertebrae are all fixed, your fractures are all fixed, there is nothing more I can do. Now you can go back home. Or now you have a metastasis. The chemotherapy is not responding and there is nothing more I can do. Or your stroke, we did the thrombolysis, now you are out of danger, still the patient is unable to walk, but there is nothing more that doctor can do, right? Can he make the patient walk and send home? Not possible. So this is the usual response that our patients get from their treating doctors. There is nothing wrong in it because that's what the doctors are focused on. They have to treat the spinal cord injury. They had to treat the thrombus. They had to stop the bleeding. They had to treat the primary tumor, which might not be possible anymore. So there is nothing more that they can do. Where the focus is disease-centered treatment. The disease is no longer responding to a particular treatment, so there is nothing more that they can offer. But when we start focusing on suffering, when we start focusing on the experience of a paraplegic patient that goes through, which he goes through the entire life, if that is your focus, there is always something we can do. Do you agree, Sister Deepika, to what I said? Do you think if we focus more on the suffering part of it or the illness experience, is there always something we can do? Or is there a point you think, okay, this is it, there is nothing more I can do?
No, ma'am, what you are saying is correct. Because suffering can lead to many other things. If we focus on suffering part, then it might be helpful for the patient to overcome his fear.
Thank you, Sister Deepika. So this is one difference that, or one major message that I wanted to convey, that there is always something which you can do when there is an illness-related suffering. So this is a Lancet Commission report published in October 2017, a huge document, hundreds of pages. But in summary, they say that globally, we have around 61 million people in health-related suffering, serious health-related suffering. 61 million. And the fact is that those who are, I'm not sure whether there are people in this group outside India, but 10 million of these suffering people are in India. So now you understand how many nurses like you we need to reach these people, right? Now we have around 30 nurses here. So to reach 10 million people, to give them good nursing care with empathy and compassion, how many of replica we want? So much, right? So many people to get trained to understand the concept of suffering. It is not just the disease, but we are talking about the illness experience. And what happens in India? The moment you are diagnosed with a disease, a chronic disease, you have to spend money out of your pocket, right? Even if we are working in a hospital, if you have a major illness, you have to pay for it. The hospital is not going to give you treatment. All the expenditures are coming from out of the pocket. Even if you're going to a government hospital, what happens? There are other expenses. Your family member will have to stay there, their food expense, they may have to find a place to take a small room nearby, then being away from job. So there are a lot of hidden expenses. So in India, it says that this report says that 55 million Indians are under the poverty line just because of the health expenditure. You can imagine, right? Even if we had to take leave from work because of a 2 weeks illness, it's going to cost a lot for our family, right? So the moment we write an investigation or we write medications, we have to make sure that this is something which is going to change the treatment plan. If I'm writing a scan, I should know, why am I writing? Am I going to change my treatment plan based on the CT scan? Or is it just that I'm curious whether the disease is progressing? So I'll just share a experience. Few months back, there was a very young male who had advanced cancer of lung. He was very young, and it was spread to all over his body, like all the vertebrae, all the possible bones, brain, and he became kind of paraplegic also. So his mother still had a lot of hope. He knew that his illness is not going to be cured, but he was advised to take a scan, a PET scan, uh, with the prescription with which the mother came to our OP and told they have written a new scan. It cost a lot. We took another scan 3 months back. So they told to take another scan now after 3 months. So I checked, and it's the same PET scan which was done 3 months back, and it shown metastasis all over the bones. And there is no other option other than palliative chemotherapy and palliative care. So then then somehow they borrowed money. They sold their last gold chain with her, and they somehow managed to do the PET scan. And after the PET scan, she came to the clinic again and asked me, "What is written in this?" So I asked, "What did your doctor tell you?" Because I cannot just say whatever I feel like, right? They have a treating doctor. So I asked, "What did your doctor tell you after seeing this report?" Then she told, we got the appointment for this PET scan. We spent a lot of money. I was standing in the queue for hours just to see the doctor, but the doctor did not look at the report. They said, okay, let the PGs take care of it. And the PGs just opened it and then gave it back to them. So then I had a few friends over there, and I called and asked, "Are you planning to change the chemotherapy regimen? Is there something more that you want to offer? Is that the reason why there is a PET scan right now?" They told, no, we just wanted to see the progression, whether it is progressing or not. And how much it cost to the family? That was the last ounce of money they had. But the moment the doctor is telling a particular investigation, their hope rises. Even I thought they are planning to give a new regimen. They are planning to change something. They're planning to do something. That's why they asked for this investigation. So that's it's not a single event. I'm sure you might have seen at least these kind of experiences while you are studying or while you are working. So this is one thing that we all have to keep in mind. Even when you ask, okay, do this investigation, etc., 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 and we don't know what we are going to do with that. If we have a plan, if I want to know whether I can start an NSAID, I need to check whether the kidneys are okay, then it is fine. Because I need to know whether the kidneys are functioning. So it is very important to understand that where these patients are coming from. Are we pushing them down to their poverty line just for getting an investigation done? And this is a very, very common myth that we always hear. The moment, I don't know how many of you have talked about undergoing course in palliative care in your family and among your friends. At least one of you might have heard palliative care is for dying people. Oh, why do you want to take care of dying people? Is it so depressing? And what is there to do anyway for people who are dying, right? Aren't they living at the moment they are dying? Until you tell that they are dead, until you certify that they are dead, they are living till the last minute, right? So I always justify myself telling that I work for people who are actually living, not dying. So this is one common myth that we go through. And coming to the WHO definition of palliative care, you don't have to learn this by heart, but I'm just highlighting a few points. What palliative care is? Palliative care is all about improving quality of life. We just look at the suffering, we just look at their journey with the illness, how much they are going through, what they are going through, and if possible, improve the quality of life, at least not to worsen the quality of life if you are unable to do that. For of whom it is not just the disease. We are not looking at the disease here. We are not looking at the tumor. We are not looking at the thrombus, but we are treating the patients, and not just patients, and their families. Don't you think the families will also go through a lot of suffering when someone is diagnosed with a chronic illness in your family? It's always a caregiver that goes through all this burden, financial burden, time issues, how to take care of this, all those suffering the family is also going through. So it is about improving quality of life of patients as well as their families. Which kind of patients? Patients who are going through life-limiting illness. So it is not just cancer, it is not just people who are dying, it is about life-limiting illness. And this is a very, very important thing that you all have to understand. It is applicable early in the course of illness. Why should we start it early? What do you think? How it is going to help?
It helps to reduce the suffering.
True, but do you think the suffering will be there from the beginning itself?
Could not be, but maybe to prolong the life.
Any other point? Why should we start it early? Can't we wait till the suffering starts and then give palliative care? Anyway,
Hello?
there are yes, Jomi, please tell.
I think we need to prepare the patient, I think. So if we start early, we will get more time and we can make a good rapport with patient and we can prepare the patient for that palliative care and as well as for the end of life care also. Throughout the journey, if we are together with them, so it will be good always to start early.
Very true, very true. Otherwise, patients will feel that the doctor is deserting them and the doctor is transferring to some other department because they don't want to take care of this patient. Very good response, Sister Saraswati and Brother Jomi. And I think in the end of this definition, there is always through the prevention and relief of suffering. So we have to prevent the suffering. We know that this particular patient, paraplegic patient, as someone told earlier, they can become bedridden, they can develop bed sores, right? We know that he might get bed sores. So it's important to prevent the suffering. If we know that he's going to get bed sore, it is important to prepare the family, as you said, very early in the course of illness so that he will not end up in a very bad state later on. So it's our responsibility to prevent suffering as much as possible. So we should start palliative care early in the course of illness. So coming back to a little bit of history, I know that many of you might know about this. So it is Dame Cicely Saunders who started palliative care movement in 1967. And this is the first hospice which is established in London, which is St. Christopher Hospice. So Cicely Saunders was basically a nurse who started to work with soldiers who were injured during the World War. And then she understood that many of them were in severe pain. And even after giving medication, she understood that she could not get complete pain relief. They were still in pain. Then she thought, what can I do more? Then someone told her that only if you become a doctor, you can treat pain. Because you are a nurse, you can't do much more than that. So then she became a doctor and later on she became a social worker. And she is the one who coined the term total care. It is not just a doctor or a nurse or a social worker alone can treat someone's pain. The care should be total in every possible aspects of suffering. I'll come to that concept in the coming slides. And we are in a country where pain relief is available to less than 2% of people. You might have seen, at least in your setting, people crying in pain and we say, it's okay. There will be pain. You have cancer, there will be pain. Or you are anyway taking chemotherapy, so you will have vomiting. It is a part of disease. So all these you might have seen and we might have told also. I have told when I was studying, when someone is in severe pain, I used to tell it's a part of illness. You have to bear some pain. You can't avoid all the pain. So pain is always undertreated. And how many of you have learned pain management when you are doing your nursing education? How many of you? At least some of you? That's great. None of us have learned. We learned only after coming to palliative care. We have never taught about the importance of pain. We were taught if you see a lesion, we are very good in measuring the lesion, the depth, the width, the surface, the induration, etc., but not pain. Asking the patient, what about the pain? How is your pain? What kind of pain? We were never taught. So at least some of you have heard about pain management. At least you know that pain is something which needs management. We never knew that. We thought pain is a part of the illness. That's okay to have pain. And I myself have seen people who were in pain when I was studying, and I was clueless what to do. I don't know. I'm not an oncologist. So all these patients were having cancer. I told, I'm not an oncologist. Please tell your oncologist that you have pain. I didn't know what to do, but they kept coming back to me, and I felt helpless, and that's how I ended up in palliative care. So, is Sam, have you raised your hand? You have any question?
Ma'am, this is Jaya Sharma from Command Hospital, Pune. Actually, I have learned about the pain. You were asking about that, so I just wanted to
Yeah,
say
great.
few
Yeah.
words that we have learned pain management due to the oncological nursing only.
Okay,
That's
okay.
it, ma'am. Thank you.
That's a great thing. Like, as I said, you are all fortunate. At least you have heard about the importance of pain. At least none of us were taught about that. You need to listen, or pain is something that you need to treat. We were never bothered about it. We kept telling that it's a part of illness, and you just become helpless when patient starts complaining to you, and you don't know how to go beyond NSAIDs. So these were the helplessness that we all went through. And thank you for sharing your experience. So this is a story, the picture, the story of Mr. H. So Mr. H was a daily wage worker, a 50-year-old gentleman, did not have any habits, a very good a father, a husband. He had his wife. Wife was a homemaker, had two children. Both of them were studying in school, not very young children, but they were studying in the higher classes. And he got diagnosed with an oral cancer. So he started having pain on inside his cheek. Uh, he went to a local dentist, and they told there is some lesion. You have to go and get it checked. And he went to a bigger hospital, and then they told you have to do a biopsy. What happens generally? Everyone will get scared. Many of them don't go back. So he didn't go back because it's important for him to go to job every day. He cannot just skip one day's work and go for biopsy and then go another day for taking reports. And he was damn scared. So he did not go. He came back home and he took some medications, local medications, Ayurvedic medications, applications, all these gargles and stuff. He tried to push the treatment. And then ultimately it became like he could not eat or drink anything. He became emaciated. He became so weak and he could not drink or eat anything. Then he was forced to go take another consultation. Then the doctors told it was cancer. Now they somehow did the biopsy. Now you have to go for radiation and chemotherapy. And they put in a tube, RT tube, because he could not swallow anything. Now he has to go through all this treatment next week onwards. So coming back to the story of Mr. H, I would like you to take a few minutes. We'll be dividing you into small groups. So you remember the scenario, right, about Mr. H. Mr. H has an oral cancer, two children, wife is a homemaker. Now he has to undergo chemotherapy and radiotherapy. RT feed is there. What is that he's going through? Now we talked about the suffering. It is not incurable yet. They didn't tell anything about the curability of it. They didn't tell it's curable or incurable. We don't know whether it is curable or incurable. And this is his picture. Now we can evidently see what he looks like and what he's going through. So we'll divide you into small groups. You first, as soon as you get into the small groups, someone take the volunteer for taking the notes and present it to the larger group. So you start discussing the elements of his suffering, note it down, someone note it down, and you come back after 5 minutes and we'll discuss it together. Is it clear? Is the instruction clear to everyone? There will be a prompt on your screen to go to the breakout room. You will be automatically assigned to a breakout room. And don't keep quiet in the rooms, because this is an interactive session. We are not trying to teach you or something or anything. We are just learning from each other. So you'll have 5 minutes to discuss this. What are the elements of Mr. H suffering? For now, back to the main session. So we'll quickly take a round among all the groups. So we'll start with group 1. Just the important points that you discussed about Mr. H. Who's presenting from group 1? Have you started discussing in the group 1?
Yes, ma'am.
Okay, yeah, please.
Yes, actually, we have discussed about the entire scenario history of the Mr. H. Basically, the problem is he was physically affected, psychologically affected, and economically affected. So we have to treat according to these 3 aspects.
Yes, thank you, Sister Chitra. I think that was room 4. What about room 1? I think room 1, Brother Jijo, you were in the group 1, right? You haven't started discussing, right? Before that, and there was some confusion about what to do.
Actually, in between, we are not discussed. I means that technical issues. Okay, then I can also share that. First of all, that patient is having physically he's suffering from pain and headache pain, and he is mentally totally distressed about due to his financial matters, and he is the one only the earning person also. Mentally he is depressed, and also all the physical strength is losing due to mental strain and disease condition also. So we need a mental health support also this patient, and also clinically he is suffering pain, headache, and that picture also showing he's having the pain also. Totally he stopped the intake also, that everything is affecting. And also he is the earning person, so economically straight, that group 1 is already said it. Economically he is thinking about the physical financial status, or maybe. So we need to think about all these things in this patient. Yeah.
Thank you, Jijo. I think you all have very good concept of palliative care. So thank you for that feedback. What about room number 2?
Yes, yeah, we were also discussing about the point mentioned by the group 4 and 1, and adding to that few points. One point we discussed about the stress related to the disease, because patient will be on so much stress because he may heard about this cancer, and he also may be worried about his children education, that is financial matter, that also one of the worry. And then maybe his fear of dying, because he may hear that cancer and he may think that it's going to be the end of life, something like that. Some kind of worry will be there, and he may fear of painful chemotherapy and radiation therapy also, because he don't have any idea about how what is going to be happen. And of course pain will be there due to this oral cancer, and it's very difficult to swallowing also, so there will be lots of pain also. One of the other possibilities that he will be in a denial phase, because initially maybe he will not ready to accept the fact that he's having oral cancer, so he will show some denial, maybe angry or some kind of can be also happen. And finally there will be lots of depression also, because he may worried about how the society is going to accept his illness condition. So these are the factors we discuss about.
Thank you, Jomi. And one more group 3.
Hello, my name is Antonia. I'm in group 3.
Yes, please.
Can I continue in the group 3?
No?
Yeah,
Do you hear me?
please. Yeah, please.
Okay. In group 3, we also looked at our points were under economical, psychological, and physical symptoms, as well as social issues. Under economic issues, we saw that there will be a financial burden on the Mr. H because he's sick. And also he has family responsibilities, which are social issues. And we also saw that he will have social exclusion because of this disease. And under the symptoms, we saw he will have pain, and he will have lack of appetite, which will bring him to have nutrition deficiency. He will also have nausea and vomiting because of that cancer. And also he will have a bad smell from the oral cavity, which is also another physical symptom. And then we saw that he will have family responsibilities that will cause him psychological disturbance, like he will get shock when he gets to know that he has a cancer. So that's what we were able to discuss in our group.
Thank you, Antonia, for that excellent discussion in your group. So all the groups have essentially discussed almost all the aspects that we were supposed to cover. So it's easier now, you understand, and I understand what you understand by palliative care. And this is exactly what I have been planning to tell also. There were a lot of physical issues that you have mentioned, a lot of social and financial issues. Who will provide for my family? Who is going to take care of my wife and sons when I'm not there anymore? When I go for treatment, who is going to take care of the financial thing? How can I go out with this kind of appearance? Can we go out to see friends and relatives, to attend a marriage? Even if you give the best pain relief possible, with this appearance, people, the change in their role or the change in their appearance, people do not want to step out of their room. Even when the visitors come, they just don't want to see anyone, because it's a matter of their dignity. They might have had might have been a very strong person. Now you are sitting helpless with an RT tube. So they may not want to see other people coming in. So they may isolate themselves, or the friends and family may isolate them. But they might be scared. What if I get cancer if I touch him? These are already there. These are still there in our society. Will I get cancer if I touch him? Can I go near him? So these kind of concerns, and a lot of emotional and spiritual issues. What is the point of being alive? Am I being a burden to my family? I have to depend on my wife or sons just to take the feed. He can't take the feed through the RT tube on his own. So he's literally telling everything was taken for granted in life. I could eat, I could work well. Now, just for going to the toilet, I have to depend on my 10-year-old son. Just to take or switch off the fan at night, I need to call someone. I'm unable to do even the smallest thing possible. So I'm actually burdening my family. If I'm not there, it's easier for them to live without me. And there are, you might have seen a lot of people in our setting, at least they consider suicide. What is the point in being a burden? Is it easier to end my life than just being a burden to the family? So what we are seeing as disease, when you become a disease oriented treating person, what we see is just the tip of the iceberg. Once you start asking, like you now discussed about Mr. H, you went below the tip of the iceberg. You went below it and you understood the huge problems that he might be going through. And that is the exact place where you make sure. Now, I understand that you're all made for palliative care because you could understand what he's going through. You are not just focusing on the disease. You are not telling he's having pain, he's just having cachexia or something, but you went underneath that and you understood. With pain, how can it affect the person? What is the suffering because of pain? It was not just the pain that you have been discussing, it is about the suffering due to pain. That is what we want to look into. And this is an old and new concept of palliative care. In the olden days, people thought that palliative care is the end of everything. Once you give all the treatment, then you refer to palliative care, and that's for end of life. That's why people still think that palliative care is only for people who are dying. But current concept is that you start, as we discussed, you start early in the course of illness. Your role might be very less. Like in the graph, you need to manage symptoms, you need to manage pain. Your role might be very, very less in the beginning, but as the disease progresses, our role becomes more and more important, where the curative options might become very, very less. And have you noticed the graph after death? So palliative care is not stop. We are not stopping to give care when the patient passes away. It doesn't stop with the death of the patient. Because we heard in the beginning, it's about patients and their families. So even if the patient is not anymore, is not living anymore, the family has to go through the bereavement, right? They lost their loved one. They don't know how to take their life forward. Who is going to provide for them? They'll be in grief. They might be in depression. We don't know. So it's very important to make sure that they cope through the loss of their loved one. So palliative care does not stop with the death of the patient, but it continues as family bereavement support care. We have gone through it. I'll just quickly go through these myths. It is not only for people dying of cancer, but it is for anyone who is living with life-limiting illness. And people always say, oh, there is no hope when you go to palliative care. That's the end of everything. When you lose hope, you go to palliative care. So I remember one lady who was in her 40s, very early stage breast cancer, recently diagnosed. She was sent to the outpatient clinic for pain management. She was waiting outside and she cried and came inside. I asked, why are you crying? What is bothering you? She told, I think I'm dying. Okay, then I looked at the charts and I told, I don't think that you have the right idea because it's very early stage breast cancer. It is a good prognosis one. What made you think like that? Why did you think so? Oh, I know what kind of people are being referred to palliative care. I have seen my neighbor dying within 2 weeks of referral to palliative care. So now I know that I'm also going to die. So it is not about giving up or loss of hope, but it is all about increasing the quality of life or improving the quality of life. And when it comes to palliative care, we do not do anything to hasten the death. Our intention is not to hasten or prolong death. We don't do any intervention to fasten the death or prolong the death. But as far as they are alive, till the last minute, and even after they are dead, we try to improve their dignity or keep their dignity as they were living. And we all think that pain is a part of illness. It is okay to have pain. When you have cancer, you will have pain. That's not the case. Pain is treatable. We can always treat pain, and then just that we have to learn the correct technique to assess and treat pain. It doesn't have to be a part of illness or dying. And many people relate palliative care for just giving morphine, unfortunately. And they feel that, oh, you people give morphine and then that's it. No, that's not the case. Morphine is one drug that is used for pain management, but it is not about hastening the death or administering morphine. Palliative care is much, much more than just giving morphine. And many people believe that if you take a lot of pain medications, you're going to become an addict. Then later on, you won't have anything to control your pain. You are stuck there. You will die in pain. That's not the case. With adequate pain management and with careful titration, you are not going to be an addict to pain medication. So these are the various phases where people go through with life-limiting illness. Initially, they get diagnosed with life-limiting illness. Then they gradually go to a terminal illness where they know that the disease is progressing, but they are not imminently dying. Then they get into a actively dying or pre-active dying phase, and then ultimately to the active dying phase. So as and when they move from the life-limiting illness to the actively dying phase, I think our role and responsibilities keep increasing. People always think the other way, oh, anyway, they are dying, what is there to care for? That's not the case. When they approach death, when they are reaching the terminal illness, their suffering will be more, the illness-related suffering will be more, and that needs more and more care. I am just skipping through this just to make sure that palliative care is not just about cancer. Majority of the patients who needs palliative care are either from cancer or cardiovascular illness. And you can see so many illness in that small graph. Neurological, multi-drug resistant TB, end-stage kidney disease, everything has its own element of suffering. And these are all chronic illness. And it is not just about adults, it's about children also. You can see a lot of neonatal conditions, children born with congenital abnormalities, other immune disorders, blood disorders, all this need palliative care. And it is for any serious health related suffering. Our diagnosis, we don't give palliative care based on a diagnosis. We need to know whether the patient is having any serious health related suffering. Just imprint that term in your head, any serious health related suffering. It is not based on the diagnosis. Whether it is cancer, whether it is COPD, it can be renal disease, it can be congenital anomalies. Wherever there is a health related suffering, we have to give palliative care. And as I mentioned, it is not just for adults. It is not just for people who are dying, bedridden, old, frail. It is for them too. There are a lot of children born with disabilities. They live for long with a lot of disabilities. Their parents have to go through a lot of suffering. Their siblings cannot go to school. So that is where we need to start palliative care early in the course of their suffering. And this is a study, landmark study, which shows that we were discussing about early integration, right? And you were telling it's important to start early so that there is a continuum of care. And there was a study done in Canada. They tried to integrate palliative care early in the course of illness, just to see what will happen. And it's shown that people who received palliative care early, they lived longer. So we kept thinking that once you come to palliative care, you are going to die. That's not the case. When palliative care is applied early in the course of illness for patients with metastatic lung cancer, they found that people lived 3 months longer than people who did not receive palliative care. Why? Because if you treat pain, if you treat nausea and vomiting, there is high chance that patients will go for treatment, right? That patient, Mr. H, he's in severe pain. Doctor told to come for chemotherapy tomorrow. With this severe pain, how can he go to a hospital? He may not go. Then we say, okay, you default treatment, you did not come for radiation properly. That's why your disease increased. So when you manage symptoms, when you are there from the beginning, there is a high chance that patients will continue their treatment properly. That might improve their survival also. And palliative care should reach people where they are and when they need it. Right? There is a huge gap between this place and the hospital. Without any illness, we find it very difficult to climb all these hills and mountains and reach a patient. What happens to a bedridden patient in this area? It's a big job for them to carry this patient from this kind of places to a hospital. I know many of you work in much rural areas. I think Kerala, we are much fortunate because it's not that health system is really good. At least everyone has some basic access. I know that many of you come from a very difficult areas. So it is about giving the care where they are and when they need it. And it is all about involving the family. It is all about talking to family, involving them in the decision making, helping them to take care of the patient. It is not just for the patient, but also for the family. And it is, when you talk about family, it is not just about wife or parents, it's also about kids. Now we heard about Mr. H. No one, I don't think, I'm not sure whether someone mentioned about the dilemmas that kids go through. Did I do something wrong? Did I curse? Because I cursed my father. Is that why he is ill now? Or he died because I did something in my childhood? What is happening to my father? Is he dying? Why is my mother crying all the time? Why there is no treatment? Is it because that we are poor? So all these questions will come to children. No one talk to them, right? Even when we go for seeing a patient, we never talk to children. Children, we think that children don't understand things, but they do understand things. So it's about supporting them to go through this illness, to continue their education so that they don't have to stop education because of the financial constraints. So this is a small collective that we have here where all these children's education will be supported so that they can have a basic education like 12th standard. I'm just, sorry. I won't be going through this. So this is a typical home care visit where there is a multidisciplinary team with whole lot of medications and procedures which is needed in a rural care, and modifying whatever is possible at home. We can't give high-tech care at home, but it is always about high touch. It's always about touch, not tech. So there, the patient can be made to make use of whatever is available in their homes and do whatever is possible, so that they have a proper treatment being done at their home setting. So it is not just about medications, but also about availability of food and basic stuff with which they have to live. So it's also about engaging the community. So palliative care is not a doctor-led team or a nurse-led team, but it is a multidisciplinary team approach where there is no leader in that. Usually it might be a community volunteer who will be understanding more than a doctor. So it's about a multidisciplinary team approach. So these are some of the rehabilitation program that we give. And I'm showing children again now, every now and then, because it's a kind of mindset that palliative care is for adults, but it is not. It is also for children. Sorry. So with that, I'll end my presentation, and I'm happy to take a few questions. Or if you want to share something from your experience, I'm happy to listen to it. I think there are participants from outside India. Can you tell me who all are there outside India? Just wanted to know how it happens in your country. I don't know I'm pronouncing the right way. Is it Jamila? Are you from, you're from which country? Anyone who wants to speak up, because when you are from another country, it might be a different perspective. The conditions, health situations might be different. Or any other questions? I can take any questions you have in mind so far. Any questions? Any of you are already working in palliative care, or are already doing associated with the palliative care in your institute?
Yes, ma'am. Yeah, Jomi here. So I am from Patna actually. I am my native place is from Kerala, but I am currently working in Patna.
Yeah. Okay. In what setting you work, Jomi? Yeah,
currently we are running a project of advanced HIV patient, and palliative care is also one of the component of our project. So so time to time we receive patient for this palliative care, and end of life care also we are providing in our project.
Thank you. Thank you. Thank you.
Myself, Ma'am Kusum. I'm from AIMS Rishikesh.
Okay.
I'm doing PhD in palliative care. It's totally related with the advanced gallbladder cancer patients.
Okay.
I'm doing that project.
Okay. Thank you. Thank you, Sister. Anyone else? Do you have any questions so far or comments? If not, maybe we can start the case presentation.
Hello, ma'am.
So yes, please.
Yes, ma'am. I just want to clarify, like palliative care does it get psychiatric illness also?
Yes. So that's a very valid question, because we get a lot of psychiatric patients, but what we do in our setting is that we are not experts in managing psychiatric illness, right? We don't know the drugs. We need a psychiatrist's help. So what we try to do is, like, we try to get a consultant on a voluntary basis for getting the psychiatry consultations done. But then we work along with them to give the total care. We might be able to talk to the family. We might be able to listen to the caregivers' issues. The caregivers will have a lot of health issues, and there might be physical issues associated with mental illness. They might have some skin injuries, falls, or oral problems. So there might be, or constipation. So there might be a lot of physical issues also, along with the issues within the family. So we work with the psychiatrist to get the medication, to get the treatment properly, and but then we'll be in touch with the patient in a home care setting or in a outpatient setting. So that's how we work, because we don't know much about psychiatric drugs. Like, we are not experts in managing that, but we work together to give palliative care. Very valid question. That's very difficult area to work with psychiatric patients, because it's a lot of distress for caregivers to deal with that.
Yes, ma'am. Thank you, ma'am.
Thank you, sister. If there are no other questions, maybe we can start the case presentation and we can take up more questions after that. Hello, Mr. Jomi.
Can you start the PowerPoint PPT?
Oh, yes.
Yeah. Hi, good evening all. Myself, Jomi Chako. I am a nurse actually. Currently, I am working in Patna, Bihar state. So here we are running an advanced HIV project. So I'm working in Doctors Without Borders. It's otherwise called Medicines Sans Frontiers also. It's an international NGO and it's an humanitarian organization as well. So I'm going to present one case here. It's a 15-year-old female child. So she's a HIV positive patient and along with acute gastroenteritis, and she's also having severe acute malnourished, and in her body there is a tinea corpus also, and she's having the complaints of airway failure also and poor adherence. That means she's not taking the airway drugs. So when the patient came to our facility, patient had the complaint of weight loss for 2 to 3 months, and she's having crested itchy lesions on all body for 2 months, and loss of appetite for 1 month, pain abdomen for 5 days, loose motion for 4 to 5 days. So she came on 7th February 2022 this year. So these are the history. So patient is known for HIV positive, no history of any allergic, no cardiovascular problem, no obstetric or gynec issues, and she diagnosed on HIV on 11th March 2013, and her drugs were started on 16/6/2017. Initially, she was on ALE, but later it was switched to ALD. As per her statement, she is taking drugs on daily basis. Her CD4 was 14, and patient was never on TB drugs. She don't have any history of Kala-Azar or any cryptococcal pneumonitis. On admission, patient was severely acute malnutrition. As you can see, her BMI was only 9.4. So on examination, her BP was 96/66 and pulse was 92 per minute, temperature normal and respiration also normal, SpO2 also normal, RBS was 131. No pallor, no icterus, no clubbing, no cyanosis, no lymphadenopathy, no edema. Her skin was dry with crested lesion. So somewhere few places there was dressing also required. Mouth, there was nothing to report. Cardiovascular also everything normal. Pulse was regular. Auscultation S1 S2 here. Respiratory bilateral air entry present. Normal vesicular breath sound here. And abdomen tenderness was present. In her epigastric region there was pain. It was severe pain actually. But no hepatomegaly and splenomegaly. Per rectum also it was normal. Ascites no, but she was severely muscle wasting was there. In her limbs, upper and lower limb was normal at the time of admission, but later she was completely on bed. Genitourinary, there was no abnormalities. So treatment base, we were treating the anemia. Her hemoglobin was very less, so we were treated with blood transfusion. 2 blood transfusions were given, and she was also treated for neutropenic sepsis and bacterial meningitis, that also treated. And hello. Yes.
Sorry, you continue. Sorry.
Yes, yes. So she was treated for this neutropenic sepsis and bacterial meningitis. And for treating a severe acute malnutrition, we were treating with easy paste. Easy paste is one of the ready-to-use therapeutic feeding food, and we are also providing this along with normal diet, and we are providing this high-protein diet also. Apart from this, she were treated for all other symptomatic treatment like loose stool, vomiting. So there were other symptomatic management also given to her. So in examination basis, her CD4 was 15, HIV viral load was 54,954. Her TB was negative, RK13 and Kalasar test was also negative. She was negative for cryptococcal meningitis. Her hemoglobin on admission, it was 5, but later it was again went low, that is 4.2. That's why we were given 2 blood transfusion during this treatment. Her blood group was A positive. Her urea blood urea is 38.7, creatinine was 1.1, SUT, SPPT, you can see the ratio. Her LFT was more or less normal. Her potassium 3.4, sodium was a little bit high, 146. She was COVID negative on admission. So we were treating with, because she's having this hypoglycemia, so we were treating with dextrose 25%, and we were provided the albendazole tablet also at the time of admission. Then she was taking her ART drugs, that is abacavir, lamivudine, and dolutegravir. We were treated loose motion also, so we provide tab metronidazole for 5 days, and she was taking cotrimazole also as a prophylaxis treatment. She was having some seizure issues, so we were providing injection sodium valproate also as a prophylaxis for a seizure. For vomiting, we were providing ondansetron, and for gastric issues, we are providing cap omeprazole. For severe acute malnutrition, we are providing easy paste that I told it was ready to therapeutic feeding food, and we were providing ORS, that's for as a part of malnutrition treatment, and for fluid management. Ointment miconazole we are applying for the skin lesions. Moisturizer also we are providing, and we are providing a few area of we were providing daily dressing also. She's having severe pain abdomen, so we were giving injection buscopan also as SOS. Tab paracetamol for both pain and fever purpose, and loperamide also given for her loose stool issue. And she were treated with this neutropenic sepsis and bacterial meningitis. Initially, she was started on injection ceftriaxone, but later her condition got improved. So the doctor thought that, okay, we can easily shift to oral medication. Then it was changed to oral medication, that is amoxicillin and clonic acid. But again, she deteriorated. Then finally, we used the higher level antibiotic, that is injection meropenem, for 7 days. So these were the medication part she were received during our facility. Next slide, please. So her psychosocial aspect was she lost their both parents, and she was really upset. She needs support to do the daily routine. She was with her younger sister, but she's also less than 18 years. So she was taking care of the patient, and she's also under 18, and she's also worried about lots of things regarding disease and how the condition goes, and she's also worried about her education also. So we were providing the psychosocial support for both patient and patient attendant also. So we have our own mental health team, so they were more focusing on the poor adherence and importance of the good nutrition. Individual section involving play therapy and cognitive behavioral therapy to increase the patient's self-esteem. And we were providing peer support with other minor patients to help her feel validated related to sadness to sorrow experience due to HIV extra. So the focus on the individual rather than the label of HIV. So because there were so many stigma and discrimination in the society, if you look at in the Patna locality, so we were more focusing on the person, so not as HIV, something like that. So after the discharge also, we were planning to do the telephonic follow-up and home visit also. Next slide, please. So these were the main concern. So she's having advanced HIV, poor adherence, and severe immunosuppressed. She's having generalized weakness, loss of appetite, loose stool, anemia. She's receiving physiotherapy also for ambulation, because in between after admission, she was completely on a bed. She was not able to walk around because her BME was 9, and she's having a severe muscle wasting. So she's not able to walk on the 3rd or 4th day of admission. and psychosocial stressors also, and absence of parents and significant other, because she don't have the parents and she's having only with sister. There were no uncle, auntie, so some kind of support also she was missing. So these were the main concern during the treatment. And on summary, she was with us, and she was admitted in our ICU. So we were monitoring the blood glucose level on every 4 hours, as it was fluctuating every time and every day. There were daily monitoring of IO charting, and vitals were taken every 2 hours. We were using lots of checklists also for the ICU patients. It's mainly for the pain assessment and other consciousness checklist. It includes the basic care, the aspiration management, airway management, personal hygiene, monitoring. So these are the different tools we were using in our facility. Daily dressing and wound dressing also done, and we.
Jumi, you got muted.
Yeah. She were treated with this severe acute malnutrition. So we were taking daily weight checking, and we were checking the MUAC also. MUAC is nothing, is the mid upper arm circumference. And we were discussing, we have our own multidisciplinary team also. It includes the medical doctors, and as I told, it's an international organization. So doctor from outside country also here. So we take an expert opinion from the outside doctors also. And we are having our own health promotion team and mental health team also. So it's a group of all doctor, nurses, expert doctor, HP team, mental health. So all together we sit and we design the plan for the next 1 week for each patient or those who require or this patient. So this case we are discussing in the MDT also. And for mental health and this palliative care point of view also, we are using lots of different checklists. That's called PPS score and DISA score, and the mental health checklist also, because if you find any mental health issue, so we have certain scenarios listed. Patient was crying, patient feels sad, patient look separate, so feeling very sad. So this kind of issues, if you are noted, then it will be informed to the mental health team. Then mental health team will do the needful for the patient. So this monitoring and checklist tool we are following during the entire course of the treatment. So as of now, today also patient is with us, but patient improved a lot, gaining weight on daily basis, and her ambulation also improved. So she's walking, she's able to walk nowadays. Patient has responded the treatment and clinically shown improvement also. So now she understands the need for proper nutrition and good adherence, because on daily basis our health promotion team and mental health team were providing the counseling session to her to enhance the patient resilience required in ensuring patient commitment to the treatment. So now we can see that the patient has some kind of motivation to take drugs and in order to leave. So because compared to initial admission phase, she was really sad and she don't want to take the drugs. She's very much worried, but now it's much better. So these are the discussion points. As Dr. Sreedevi mentioned, that palliative care is not about during the facility. So palliative care starts at the admission and it goes beyond discharge also, or beyond the death also. So we are thinking about how we can support her. So as I told, her elder sister is there, and the financial matter is taken care by maternal uncle, but she's having some stigma and discrimination related issues because she didn't turn to our facility. He's in his home. So we don't know exactly what's happening in the family, but we know that there is so many financial support required for this both kid. So we were trying to find an NGO working for children, or any malnutrition program in their respective society, or any home-based palliative care. Any people are working in their respective district or society, that also we are finding out. And we are going to connect with her in the government schemes, because for HIV patient, and there is lots of government schemes are going on for their education and other benefits. So that also we will connect with the kids to that system. And we also to ensure to assess ART drugs, and by connecting with her respective ASA worker in their locality, because it's very important in HIV cases. We need to take ART drugs on daily basis. We cannot skip the drugs for even 1 day. So we are going to connect with this patient to their respective ASA worker also. So this is my presentation, and yeah, thank you. Thanks a lot.
Thank you, Jomi, for that very detailed presentation. I would like to ask, anyone in this group have experience in patients working with patients living with HIV? Anyone who already works with, I mean, other than from your group, I think you have a few more members working with you, right?
Yeah,
Patna.
3 more nurses are there.
Yeah.
Yeah.
So other than that, is there anyone in this group who have worked with patients living with HIV? Just want to hear from them. Or what do others think can, as a palliative care, if you become a part of a palliative care team, what all can be done? I think they have done an amazing job. You have covered every possible aspect to make sure that they adhere to the treatment, and with the CD4 count of 15 and so much of viral load, now she's able to gain back weight and became ambulatory is something wonderful. So that's yeah, that's something really great that your team have done. But I would like to hear from others. Is there anything else that we need to do more so that the adherence will be continued? There is no problem with that, or the nutrition. So I'd like to hear from other participants. That's a pin drop silence. This has to be very interactive. You can tell anything. There is no right or wrong answer. There is no right or wrong answer in this, because many of us may not have the experience in working with palliative care or elderly care or pediatric or HIV. That's fine. But the concept remains the same, whether it is a child or an adult or HIV or cancer. So what do you think? Suppose your friend is asking you, okay, this is the problem. What do you think? I have done these many things. What should I do more? What will you tell them? Should I start calling names? Yeah, Kusum, please.
For increasing the adherence, we should enforce the family members who is the back support of this patient. Like they should be included in that planning, and we can get good adherence from the patient side.
I think there is only one maternal uncle, and because of the stigma, no one wants to. That's what I understood from what Jomi said. Only the sister is staying with the patient, and obviously she is just under 18, and she'll have her own crisis and coping issues with all this happening in her life, because she's also a child. And I don't think essentially they have a family. I think these children are on their own. But thank you, Kusum, for thinking that way, involving the family to make sure that they adhere to
those who are like some maternal family members, or anybody who can be the support system for them. You can search.
Jomi, how far the community can be involved in patients living with HIV? I understand the depth of stigma. I have a very short, a year of experience in working with HIV and palliative care. So I understand the extent of stigma that they have, even for talking about it. But then, do you think it is possible to involve some of the community members to?
Yeah, I think she have a valid point that exactly what we are doing in a normal scenario. If the parents or the family members are there, we are definitely will connect with them, and we will promote the adherence and everything. And talking to this, our setup. So our setup is in Patna, that's the capital of Bihar, and we are getting patients from all different states, all different districts in Bihar actually. So it's quite distance actually. That is one of the main challenges that we are facing here, because we cannot do the home visit on whenever required. So most of the time, telephonic consultation, that's only way we are getting. And we are trying to get any other connectivity also, because we want to know either any other palliative centers are there, and so that kind of thing we are trying to get. But so far, I think there is a system, but if it comes to the HIV things, still there is lots of stigma, discrimination there. So that also one of the very challenging part for us. So we have our own limitation, and that's a difficult part also.
Yeah, yes, Sister Saraswati, you wanted to tell something?
Yeah, is there any way like where we can introduce some occupational things where, you know, one thing is to promote, I mean, or how to say, like involve them in what they know.
Yeah.
Or
something
bring
like
back, bring back their interest basically.
Yeah. So, you mean some vocational rehabilitation where we can,
Yes. Yeah.
so that's something that we do here also, like very good point that they get engaged, they get distracted, and they feel they
Yes.
are useful. It can be like here it is umbrella making or pen making. They don't have to put a lot of physical effort into it. And then you find some NGO who can market it through social medias or something. And then they feel that they are, as you said, you were mentioning about the self-esteem. They feel that they are doing something and
Something. Yes.
they are being useful, even though they are sick. That may not bring in a big amount or something, but it brings in a lot of dignity to the patient. Yeah, very very valid point. Thank you, Antonia. You have a point, please. Antonia, you can you tell me where you're from, where you're working?
Oh, yes, I work in Uganda, in an organization called Hospice Africa Uganda.
Okay, yeah. So you work with Dr. Moira?
I work with Dr. Anne Merriman. Dr. Moira is in the city of Kampala. Me, I'm in another.
Okay. Yeah, please tell, please. I understand that you have a very good experience in dealing with patients living with HIV in your hospice.
Most of our patients, because there is a very good organization for HIV care.
Okay.
So the founder of hospice felt it is important to care for the cancer patients who are neglected.
Okay, okay.
Yes, yes. However, but I'm thinking one thing that I see works very well here for HIV patients is counseling.
Okay.
If it can be added somehow, I know it is difficult, but they have professional counselors.
Oh, yeah. Okay.
Who patients can see, and it can help a bit. And then there's also where they teach patients to be counselors to patients, peer counseling.
Yeah.
So if there's a possibility that there's another HIV patient close by,
yes,
more adapted and has tried to adapt, can help another patient to also adapt. And then I'm thinking another thing that can be helpful is to involve a spiritual leader of the faith of the patient.
Okay.
If it is possible that there is someone who can come and visit them at home and pray with them in a way that they understand, to understand those existential issues.
Yes,
like,
yes.
Why am I alive? Why is God abandoning me? Some spiritual leader can help, even counseling. Those two things,
I'm sorry, we are unable to hear you.
People, but if you can.
Oh, yes, sorry. Yes, please continue. In between, we had a network.
Spiritually, oh, sorry.
Now we can hear you.
Counseling and spirit.
Okay.
Yes, I was thinking of those two things could be added to the care if possible.
Yeah, thank you, Antonia, for your points, because you might have seen patients like that than any of us. I understand. Thank you so much. And that's a very valid point, Jomi. Peer counseling works a lot. I have seen people getting really into that because when you tell something, okay, everything will be fine, this is going to be like that. I have heard patients asking, how do you know about it? You have not gone through it. I'm the one who is going through it. I know about this. You are healthy, so you can say it. But when they have their peer telling them what they have gone through, how they worked on their adherence, how they improved this thing, and how they can be more useful, then they have someone to relate to. That really works. There are peer support groups run by NGOs. I'll find out whether there are some in Patna, but usually there are one or two agencies which have this peer counseling where people living with HIV will be giving support to the others. That works really, really well. So they find that they are not alone in this. And another point that I wanted to contribute is about asking why she is not adhering to the treatment. You might have already done that, but very often the children with HIV, they become so angry towards their parents. They can't forgive. It is because of them I have to suffer like this. And the other sibling is not positive, I guess, right? She's normal. So that is something that we see. One daughter or son is normal, and I have to go through all this. Why is it just me, not her or him? These are the questions that they usually come up with, and they are so angry and they can't forgive their parents. So that's, and at that age, you know that a normal child will be very rebellious to everything. They don't want to do things which parents tell, or they want to do their own stuff. And that is a very common age where we see this non-adherence problem in patients living with HIV with very limited experience, but that's what I have seen. Because that age of transformation, they decide, okay, I know what is good for me. And all these background issues that only I am infected, and it is because of them, they did something really bad, and now I am suffering for it. So these kind of things will be behind their. It's not just not interested to take medicines or not wanting to take medicine, but these are the things that they usually go through. So it's very important you will have excellent counselors, I understand. They might have done this, but that's what I just want to share from my own experience. I have seen, like, when the other sibling is normal, then this sibling will feel terrible. It's just me going through all this.
Yes. Thank you. Thanks a lot for the comments and the suggestion. Yeah.
And we'll try to, we have a directory in the Pallium India website where we have a state-wise directory where we have a list of services available, palliative care services available in each state. So if you just go through it and let us know if you want to get connect with any of them for your, I understand when you go out of Kerala, it's very difficult. The access is very, very less, but whatever agencies are available is listed in the website. For any one of you, you can just get into the website and see which state where you have people working in palliative care. You can get in touch with them and you might be able to explore it.
Sure. I think we are already looking into that when we heard about this training, and I went to this directory also, and I got the number, I think, and our mental health team, they're doing the follow-up of this. They're finding out where they can contact.
Thank you so much. Thank you so much, Jomi and team, for bringing up this wonderful discussion for today's session. And that's very different from usual discussion, because we started with the child. We usually don't talk about children when it comes to illness and death and stuff. So we have had a good start. Thank you so much for that. And thank you so much, all other participants. The silence is not accepted anymore. From next session onwards, everyone has to speak. This is the first session, so I didn't want to nag more than this. But please be interactive because there is no hard and fast rule in this. We all like, I learned a lot from today, from Jomi's presentation, a lot. Because initially I thought this much CD4 count and viral load she might have, I did not think that she might have recovered. So we all learned from you. So please be interactive, and thank you for joining today's session. Over to you.
First of all, I'm thanking you for being with us today, and I'm expecting this kind of participation from you again for the next class. And Sreedevi ma'am, thank you. And Jomi Chako, thank you for this wonderful case presentation. And I'm expecting all of you to send your case presentation before the end of this week. You have an example before you now, so it would be more easier for you to do your case presentation. And without case presentation, we cannot, you cannot complete your course, and you cannot get a certificate on this foundation course in palliative nursing. And we have a feedback link for you. Just go through that link and give feedback for this session. And it will be very useful for us to improve ourselves through your feedback. So the link will be provided in your WhatsApp group. So please go through it and give your feedback to us. Thank you all. We'll meet you on the next class. Bye-bye.
Yes, Antonia, we'll be sharing all the presentation and the recordings for all the sessions. So don't worry about it. We'll be sharing it.